Over to Gautam.
Thank you. Thank you, President Sir, my dear friend Dr. Prakash Trivedi, for such a kind introduction. Respected chairpersons, ladies and gentlemen, the topic I'm going to speak today is something we really need to think about, particularly in India. And at the end of the talk, if I can change your opinion about how many embryos you are going to transfer, then it will fulfill our purpose and you will get lots of blessings from your pediatrician colleagues and also from the parents who apparently are very happy with the pregnancy, but eventually, perhaps after a year or two following the birth, they realize that it wasn't a happy ending at all. Now, I put the title of my talk, Back to Square One, because we all know in the very first IVF, Patrick Steptoe and Robert Edwards, they collected only one egg, fertilized that egg in a natural cycle, and transferred only one. Then subsequently what happened? We wanted to improve the success rate. So we started controlled ovarian hyperstimulation. We started in this city only by Dr. Subhash Mukherjee with the help of gonadotrophin. Obviously, we got more embryos, and we wanted to transfer many more embryos so that we can improve our success rate. But that led to higher incidence of iatrogenic twins and other higher order multiple pregnancy, leading to higher maternal risk and poor perinatal outcome. So much so that we are ending up doing selective fetal reduction and resulting in associated complication of pregnancy loss. So I say this all the time. We Bengalis, we live to eat. We don't eat to survive, but we survive to eat. So we are greedy fellows. So instead of eating too much and having indigestion, isn't it better to be more rational like our President Sir, who is obviously maintaining his figure largely because of his diet and exercise and disciplined lifestyle. So what we want to say, past is past. Whatever we have done in last 40 years, 4 decades, fair enough. Let's change. Our goal should be one healthy baby at a time. So I will have one rasgulla at a time, not like 5 or 10. And why should we do this? We all know multiple pregnancy has risks of pregnancy-induced hypertension, gestational diabetes, placental abruption, placenta previa, higher operative delivery incidence, and postpartum hemorrhage. And remember, these risks are more in those people we are doing assisted conception, like elderly, obesity is pandemic, essential hypertension, heart disease, kidney problem. Now, these women never dreamt of having a baby before, but with the advent of ART and with the improving facility, the average age of our mothers are much higher. Many of them are in their 40s. Now, we know there are perinatal risk as well. The risk of preterm birth is almost 5 times. Low birth weight, very high. Perinatal morbidity, cerebral palsy, and developmental delay is as much as 4 times higher. And again here, these abnormalities are more common in high-risk cases, which we are dealing day-to-day practice, hypoplastic uterus, uterine malformation, cervical incompetence, and previous history of premature delivery. Again, these women were not pregnant before, but now they're getting pregnant, and that multiple pregnancy makes it even more risky. Now, there was an international registry published long time back by Edwards and Ledwig, and in that international registry of IVF children, it was shown the risk of birth defect was higher in IVF babies. Risk ratio of abnormality was 1.2 to 1.4, but it was largely due to, as I have mentioned, high risk like elderly, obese, hypertensive, diabetes, poor egg and sperm quality, and it was concluded that it is the multiple pregnancy which was the main culprit. And IVF itself was not responsible for the birth defect, but we were doing IVF in those cases where the birth defect is inherently higher. Why we say this? Because there was no increase in birth defect in low-risk patients with single pregnancy after IVF. Now, if you look at the outcome of the babies following singleton pregnancy with IVF, we see higher incidence of IUGR, APH, premature rupture of membrane, premature delivery than a natural single pregnancy. However, no difference in outcome with the natural twin. So IVF single is similar to natural twin. And it was shown that those patients who had first trimester blood loss, they're associated with poor pregnancy and neonatal outcome. And there was a linear relationship between the number of embryos we transferred and the first trimester blood loss. So it was concluded that many of these singleton following IVF were actually twin to start with. So they were vanishing twin syndrome cases. So they were twin to start with, but because of early bleeding, by the time we detected the pregnancy on ultrasonography, we thought they were single, but they were actually twin to start with. So that is why even in singleton following IVF have a higher perinatal problem. And how can we reduce it? By only transferring one embryo. So if you transfer one embryo, there is no chance of vanishing twin syndrome. Now, what are the implications of multiple pregnancy? It significantly increases the healthcare cost. Severe stress experienced by the patients, and many of these kids will require lifelong support. If you deliver a baby at 26, 28 weeks, what is the outcome of that baby and family? So thereby, it's not surprising that there's a raving criticism questioning the justification of entrusting the responsibility of our children's health in the hands of those involved with ART therapy, so-called reproductive scientists, so us. So we are deciding what will be the outcome of our future generation's health. Is it correct? Are we playing God? Perhaps we are. So we need to really introspect and decide what we want to do. Now let's go back nearly 22 years. What happened was this interesting studies showed that if you have only one embryo, you transfer that embryo, the success rate is 20%. If you have two embryos and transfer them, success rate is about 30%. But if you are not greedy, out of those two embryos you have, you electively transfer one. So I'm saying my title is elective single embryo transfer. You're not transferring a single embryo because you have just got one. Maybe you have got many, 5, 10, doesn't matter, but still I would transfer one. And what they show, if you're not greedy, if you're just transferring one, your pregnancy rate is same. So even if you transfer two or selectively transfer one, the success rate is same. Subsequently, it was shown interestingly that if you divide your cases between fresh single, fresh double, one fresh, one frozen single, and then two fresh and two frozen. That means in the first attempt you transfer two fresh, and subsequent attempt you transfer frozen. You look at the pregnancy rate. Fresh single about 30%, fresh double nearly 50%. But instead of transferring two fresh, if you transfer one fresh and one frozen, that means she's not pregnant on the first attempt subsequently. So the cumulative pregnancy rate is same, about 50%. But if you transfer two fresh and two frozen, your success rate goes up to 60%. We are very happy, but out of those 60%, nearly 40% will be twin pregnancy. And that's what we don't want. At the end of the day, your success is when the mother is going home with a single full-term baby, with a single full-term healthy baby, and that is success, not the pregnancy test, not the ultrasonography picture. Now, subsequently, the same information was repeated by another group of studies. As you can see, if you go up to blastocyst, we were not doing blastocyst earlier, but when we started doing blastocyst transfer, if you do a single blastocyst transfer, your success rate is almost 53%. And double blastocyst, same, 54%. But look at the twin difference. Single blastocyst, 3% twin, double blastocyst, 51% twin. So, why we are getting such good result? It is not because of the number of embryos we are transferring. It is because of the evolving embryo culture technique. So we should thank our embryologists, the clinicians. You know, I was trained up with this idea, which I'm sure Prakash will agree. that 80% of the credit of assisted reproduction should be given to Preeti and not to Prakash Trivedi. And that is what I've been told, that all the credit, you respect your embryologist, you salute your embryologist, and give the credit to your embryologist. And there is not much credit in collecting the eggs and putting the embryos back. Now, let's look at the data, all published. We have randomized trial and we have cohort studies. And we divide them in set, that is single embryo transfer, double embryo transfer, and twin percentage. And what you see, in all randomized control trial, it was shown the single pregnancy set pregnancy rate is about 40% and double is about 50%. Cohort studies published earlier showed the success rates were very similar. But what is alarmingly high is as soon as you transfer 2 embryos, I'm not even talking about 3, I'm just talking about 2, your twin pregnancy incidence goes up to nearly 1/3. And this is a summary of all the important paper published. In one side, we have only fresh cycle. On the other side, we have fresh and frozen cycles together. And all these people showed that your pregnancy rate is not that different between single and double embryo transfer. Well, it is different, but what you can do is if you can transfer one fresh and one frozen, then even with single embryo transfer, your pregnancy rate is as similar as double fresh embryo transfer. Now, the Scandinavian countries have shown us the way. They were the first group of countries where the law came that you cannot transfer more than one embryo. Otherwise, you lose your license. Even UK has now come down to 2 embryos. But there is no rule in US, and there is no rule, obviously, in India as yet. And if you look at between 1997 and 2004, what you will see that the pregnancy rate with single embryo transfer, the incidence of single embryo transfer has gone up significantly. From the year 2001 to 2004, it has gone rapidly up. Now, the pregnancy rate, which is in blue, has remained more or less same. So, although they were doing single embryo transfer, the pregnancy rate has maintained. It hasn't gone down. Now, the incidence of multiple pregnancy and miscarriage has gone down since they started practicing single embryo transfer. So, it's a twofold benefit. So, your pregnancy rate is more or less same, but pregnancy loss is less. Now, how do you decide which embryo to transfer? Now, you can either decide it yourself, specific embryology experience, or you can take hope of embryoscope. Now, we have talked about embryoscope this morning. You can look at different aspects. There are different parameters. You can look at pronuclear oocyte and decide which embryo has good prognosis. I wouldn't go into the detail. You can look at them at different hours, and these are the criteria which helps us to decide which is the ideal embryo. If you look at the number of early cleavage embryo transferred, and according to the number of early cleavage embryo transfer, your success rate improves. So that is one criteria of embryo quality. You can look at the blastocyst and decide which one to transfer. So you can grade them with the features of inner cell mass and the features of trophoectoderm. You can grade them A, B, and C. Now, with these two, you can have either AA or AB or BC, something like that. Now, this is a whole list of grading system of different types, and our embryology colleagues are experts, so they decide which one to transfer. You can do sequential analysis of morphometric features during embryo development, looking at different hours, and then decide which embryo to transfer. So in summary, the best embryo quality or best embryo features for elective single embryo transfer, there should be at least 4 to 5 blastomere on day 2. There should be at least 7 blastomeres on day 3, absence of multinucleated blastomere, less than 20% fragmentation on day 2 or day 3, expanded blastocyst on day 5, and intact embryo after thawing in FET cases. Now, we have been talking about non-invasive assessment. It's still a dream in most of the IVF centers because of the cost implication, but obviously we will reach a time when different biochemical levels will tell us about the embryo quality, which is the non-invasive assessment. Now let's look at, can we do elective embryo transfer in every cases? No, we cannot. That's a reality. So what are the recommended criteria? The patient should be less than 40, because the older the patient, the embryo quality is not so good. So the success rate will go down. It is not suitable in poor ovarian responders with severe male factor and intrinsic fertilization defect. If you have someone who had maybe 2 or 3 attempts of previous unsuccessful ART, you can still go ahead. But someone who had 5, 6 attempts, you cannot do that. I had a patient who had 6 failures in the first center, 5 failures in the second center, and then came to us and we gave her pregnancy on the 4th attempt. So she conceived on the 15th attempt, and I saluted her because there are very few patients who would persevere that long. Now, you need to select. If you have one good embryo and one poor embryo, then obviously you're going to transfer the good embryo. But if you have at least 2 good quality embryo, then transfer one and freeze the other one. But it will only be done, the recommendation of ASHRAE and ASRM, everything is you only do it if you have a reasonably good ongoing pregnancy rate, your multiple pregnancy rate is very high, and you have an efficient cryopreservation system. Now, I've been practicing ART in Kolkata for about 15 years now. So in the first 5 years, my multiple pregnancy rate was about 40%. And I was very proud that my unit was giving good result. But when I went abroad, the first thing they asked me, they didn't ask me my pregnancy rate. My colleagues, my teachers asked me, what is your multiple pregnancy rate? When I told 40%, they said, it's a big shame. It's a big shame. You must change. You must change. So I came back. We sat, made meetings. It's very difficult to change people. You know, the habit is something you get used to it. So my team said, no, my pregnancy rate is going to go down. We are not going to do blastocysts. You know, it's like long protocol and agonist protocol, antagonist protocol. You hesitate to change. But I said, no, we have to do it. So we started doing blastocyst transfer and single. And we very proudly say that our success rate is same. Yes, we don't do 100% single embryo transfer, but 80% of our patients are single embryo transfer. And our twin pregnancy rate has gone down to about 5 to 10%. Not even 10, about 5 to 8%. Now, let's look at the health economic aspect of single embryo transfer. The cost of a twin pregnancy delivery is 3 times more than single. If it is triplet, it's 15 times. Now, I'm in private sector. I'm not in medical college. So the cost has, so when a patient is coming for IVF treatment, they ask, what is the cost until having a baby? I say, yes, I don't know. Still give us an estimate. So we give them some estimate. But just imagine someone having triplet, that estimate will be multiplied by 15 times. That's an impossible thing. And we have to be honest. It is true the single embryo transfer will need more cycles to get the success. And we have to make a plan, like this will be your cost. So what we do, give them per egg collection. So if they have 2 attempts of embryo transfer, that should be considered as 1. Money saved by avoiding multiple pregnancy with elective single embryo transfer would fund all IVF cycles in a year. Can you imagine that? So the cost of all IVF cycles in a year is equivalent to the cost of delivering the multiple pregnancies and looking after those kids. Implementation of 2 embryo transfer would double the number of IVF cycle at no extra cost. So instead of transferring 3, if you transfer just 2. And acceptance of elective single embryo transfer would be higher if the patients are charged per oocyte harvest and not per transfer, which I just told you a little while ago. So in summary, ladies and gentlemen, the practice of elective single embryo transfer is successful, definitely successful in lowering the multiple pregnancy rate without reducing the overall pregnancy rate. This is something we have to be very sure. Otherwise, we are scared that my success rate is going to go down. It is equally effective, but substantially cheaper with a lower complication rates in comparison to double embryo transfer. But elective single embryo transfer is recommended only in selected group of patient, because if you force everyone, even the patients with a low prognosis, like elderly, like poor ovarian reserve, then overall success rate of your unit will go down. So in conclusion, I would say elective single embryo transfer is the way forward. We have to change. Substantial reduction in maternal risk, significant improvement in perinatal outcome, but we have to properly select the cases. Otherwise, it is not like a blanket treatment for all. Embryo quality assessment is important. Now the question is whether you depend on the eyes of the embryologist through microscope, or whether you have an embryoscope or other non-invasive method like PGDA, invasive or non-invasive method. It is up to you. We have heard this morning that at the end of the day, they are not really of any significance. Cumulative success rate is the game. So I tell my patient, they often say, you are the only person we have visited in this part of the world where people say you have to try 6 times. So I tell my patient, you plan to have 6 treatment. We have 3 categories of charges. So I say, instead of going for the most expensive on 1 or 2 times, rather you choose the cheaper package, cheaper cost for 6 attempts. And we need to counsel. So there has to be a balance between the reality and expectation. So what we are doing, we are giving them lots of hope. And when they are not getting success, they're demoralized. But if we reduce their hope and tell them, no, it's a like long-term plan. So I say this, why we have 5 matches in Wimbledon, in tennis, in cricket? Why our politicians have a term of 5 years? You know, in school, every year you go to a different class, but why in medical school we have 4 years? That means you need to give yourself more time. And health economic benefits would actually be better if you can convince your patient, your institution. So the take-home message would be all IVF centers, and I hope we will be able to implement this through ISAR, must try and reduce the number of multiple births without compromising on the success rate of the couples by doing single embryo transfer. Thank you very much. I will thank you for your patient hearing. I would like to see like this mother with one baby at a time. And finally, I would request you, I take this opportunity, we have been trying hard to give national award to Dr. Subhash Mukherjee, Dr. T.C. Anand Kumar, and Dr. Baidyanath Chakraborty, the first, second, and third IVF inventors of India. And we have started a signature campaign, and that's www.change.org. You can go into that. We have about 5,000 signatures already. A governor of West Bengal came in our previous meeting and assured us that he is going to take it forward. We are asking for Bharat Ratna. If we can get it, fantastic. But at least some form of award will help us. We will try together with all our support from ISAR and all other organizations. Thank you. Thank you for your patient hearing. Thank you.